Hey, can you stop sharing for a while? I think presenter is trying to share.
Yeah.
Fine.
Good evening, sir. Should we
Good
start?
evening. Yes, yes. We are ready.
So, good evening, everyone. On behalf of IIT Tuesday PG Clinic, I extend a warm welcome to all our respected dignitaries, faculty members, residents, and participants. We are privileged to have Dr. Yogesh Parikh sir, Nehal madam, and other IAP members with us today. It is my privilege to welcome Yogesh sir. On this today's academic session, I request sir to kindly say few words and blessings for this program. Yogesh sir.
Thank you, dear madam. Please, this is academic program. Please go ahead. Best wishes for the program and thank you very much, Dr. Prajapati sir, for continuing this program more than dates. Thank you, sir.
Thank you, sir. It's my privilege to welcome our expert speaker, Dr. Baldev Prajapati sir. Sir is truly a teacher of teachers and has been tirelessly contributing to academic activities and PG teaching since many years. So we sincerely appreciate and thank sir for his constant dedication, guidance, and inspiration to young pediatricians. Our today's case presenter is Dr. Akshat Dwivedi. Under the guidance of Dr. Kiran Bhaisare Madam. Madam is Associate Professor in the Department of Pediatrics at Vilasrao Deshmukh Government Medical College, Latur. And Akshat Dwivedi is the resident in the same medical college. So welcome to both of you. And thanks to Trupti ma'am for taking the initiative and initiative in this academic activity. So now over to you, Baldev sir. We can start with the academic programs sessions.
Right. Good evening, friends. Welcome to this our IAP Tuesday PG Clinic. And I appreciate everybody who is contributing for this our learning program. I learned that Dr. Akshat is a presenter and Dr. Kiran Madam is a mentor for this today's session. So, Dr. Akshat, I think before we start, can you identify some of your friends, those who are on the screen, so that we can incorporate them in our discussion, we can involve them? Is there anybody from your place? Dr. Akshat?
Sir,
I think
till now
it's
no one
time.
is from till now no one is from my institute.
Sorry, doctor.
Till now no one is from my institute, sir. This
Okay.
Sangharsh sir is from my college, from my department itself. Sangharsh Rahul.
Sorry, I could not locate them. Are they on the screen?
So, yes, sir. He has joined, sir. Sangharsh.
Sangharsh,
Rahul.
you said.
Yes, Sangharsh.
Okay, Sangharsh. Anyway, I think what I request them that please, when we start the discussion, you can join, put your comments, responses, even you can ask some of the questions to the presenter, to me. And I think that's the way that how all of us can learn. With this remark, I request Dr. Akshat to share his PPT and start this history part of this today's case. Dr. Akshat, please.
So is it visible to you?
I think I have done requested in the past also to all the presenters. Probably every time the presenter is changing and he may not be present in this discussion, don't label this case, because we don't, in the exam also don't try even. Because
Yes.
what you are discussing, cerebral palsy, may not be cerebral. I think today let me try that it is not cerebral palsy. Not at all. Whatever the evidences we have, Dr. Akshat, and in the exam it may happen so that you are prepared for this particular condition, but not necessarily that examiner will focus on that condition or the discussion. Ultimately, he wants to know that how much pediatrics you know, right? So better to just, you can say it's a clinical case discussion. Even may not be the system center or a system. What you say CNS may be even the same manifestation with other system. So all the, I will say, presenters and residents, not only from this our discussion point of view, but please take care for exam also. Anyway, start your history.
So this patient presented to us, named as Arman Yashin Nechalgar. He is a 12-year-old male child, Muslim by religion, and resident of Shri Krishnanagar, Latur. The informant is mother, and she is very reliable. And child is not a child is
Another point from exam point of view again. Some examiners may not like once you speak that mother is reliable. Mother is always reliable. Whatever the, I will say, information she is providing may not be according to your thoughts, but whatever she has observed, her understanding, she is stating, and she is always reliable. I have seen in the exam that some examiners don't like this comment if you make it. I know that you are making for the clarity that the whatever the information you have gathered is quite reliable. But once we use the adjective for the mother as reliable, many examiners don't like. So better not to say. You can say that mother is a informant for this particular case. Okay. I think I will convey some of the points from the exam point of view also, so that you will be having the less of the issues in the exam. Please continue.
the child is born out of non-consanguineous marriage, and her chief complaints was delayed attainment of developmental milestone noticed since 8 months of age, and tightness of both lower and upper limbs noticed since 1 year of age. And as the insult is likely to be in the antenatal or natal period, so I'd like to start from the antenatal history itself. So in antenatal history, mother's age at conception was 20 years, and paternal age at conception was 23 years. Conceived after 3 years of marriage, conceived spontaneously, and she is primary gravida. No history of previous miscarriage. Mother blood group is B positive, and mother weight at conception was 56 kg. And first trimester, she was registered in
Anyway,
nearby PHC.
can you
No
stop
history of
sharing,
excessive.
Dr. Akshat? Can you stop sharing for a while before you go further information? I think our aim is to discuss whatever you have stated the problems of the child. I think here 12 years old boy is there. The main problem in the exam, what the examiner is going to ask, why a child was brought to you at present? That means what were the complaints of chief complaints at present?
Actually, at present, the child is brought to us for routine checkup only.
Yeah. So I think, in the exam, many times it happens. So in this type of chronic illnesses, like cerebral palsy, suppose 12 years old boy, the condition might have diagnosed in the past long back.
Yes.
May not be probably the reason at present attending the OPD for the delayed development. So better to start, I will say, our history or narration, whatever the, I will say, situation for what the child is brought to the OPD. Many times what happens in the exam, that just for the exam point of view, the child is asked to appear on that day. may not be having any illness. And in that case, you can say that the child is having the chronic illness going on since long, early childhood. And for this particular exam point of view, child is asked to come today, and the history which I gather is like this. Or suppose this type of chronic illness and child might have brought to you for cough, cold, or vomiting, or diarrhea, or something, and chronic illness may be the part of it. So the point is, in such type of the cases, many times it's a confusion to the student that how they should start the history part. How should they should start it. And therefore you can say that because the illness is chronic or it has started from the early childhood, let me start the story from this birth history. Something like that. So that you can prepare the background that how you are going to present this particular case in these type of illnesses, right? So that it becomes easy for you and your examiner will accept you. Anyway, now coming to the complaint that there is a delayed development which the parents noted at 8 months. But Akshat, what parents observed at 8 months and they decided that the child is having the late or the delayed development? What was their observation?
In such cases, parents compared their child with other other similar age children, or if they have a previous child, so they tends to compare their present child with them, like neck holding, like rollover, like when child learns neck holding and rollover.
That was the point, Dr. Akshat. What I wanted to say that before 8 months also, mother might have noticed, not only 8 months. I'm sure that even the general mother, general person, even they know. And not only the 8 months, but before that, it is possible. The child is brought to the medical person or in the OPD at the age of 8 months. But they might have noted. And then you can say that exactly at what age they suspected, they observe, they notice that the child is late in the development. And what was their observation? Exactly you can, I would say, state like this. Then it becomes an impressive history. I'm sure that you can ask a direct question. At what age the first time child was brought to the medical person for the delayed development? At what age first time they attended the medical person or doctor?
At 1.5 years, they appeared to the medical.
Okay, before 1.5 years, they didn't go to any medical person?
No.
No. First time they went to medical person at 1.5 years. Okay.
Yes.
Then you can ask even, because the same thing is going to be discussed in the exam also. Why they waited for 1.5 years? What was their concern? There can be the different reasons. Some parents will consider that, okay, gradually it will come to normal. Some parents will consider that, okay, now there is not going to be any improvement. There is no any meaning of going to the medical person. It is possible that they may be staying at a very remote place where it was difficult for them to go to the medical place. Right? So there can be these various reasons. Or even the local doctor might have told them that now the child is not going to improve. At what other place you go? And therefore probably they might have decided. Then somebody must have even, I will say, talked to them or motivated them that it is better to consult some doctor. And that's why late, but they came at 1.5 years.
Yes.
So you know what I mean to say, that this type of history is always there. And it is expected from the postgraduate student. For MBBS student, it's okay. Whatever they will say, I will consider. But for the postgraduate, it is expected that mother may not complain all these points. But you will derive this information from the mother. You can ask the mother that why you didn't think for the 1.5 years to go to any medical person. Whether you were thinking that the child is late in the development, or how did you come to know? There may be all these points. So in the history, you should go for all this information, and that becomes the impressive history. That you know all these points and you have comment. Anyway, this is just to draw the attention of every student that in these type of the cases, always go in the details. Now the delayed development noted at the age of 8 months. Right. What can be the various reasons for the delayed development? Simple question.
There may be firstly maybe constitutional delay, or child may have any chromosomal abnormality.
Okay, can you give one example of chromosomal abnormality where delayed development is there?
Like in Down syndrome.
Okay,
Like in
very
Down
good.
syndrome, there's
Most
less
common.
intelligence, and in Zellweger syndrome, there's less intelligence part, and in
Who is I will say
Prader-Willi
from
syndrome.
other who is from other your other students, your other colleagues from your institution or even some other institution? Sorry, I may not be able to locate who is the student. Anybody can point out that what can be the various reasons for the delayed development? Already Akshat answered some of them. He said that maybe the chromosomal malformation, like most common Down syndrome. Yes, maybe the different stages of the development delayed, but it is one of the reasons. Anything else, anybody? I think Dr. Pranay. Yes, please come on. Come on. Please unmute yourself. You are muted. Dr. Kiran. Yes, anybody else? Sagrika, I know that she is now consultant. So she has put the very important cause. Sometimes I was going to ask that any endocrinal and congenital hypothyroidism. Yes, it can come as the delayed development. Suppose selectively malnutrition, yes. Dr. Amisha, better to speak rather than to put on the chat box. We are not, I will say, just, I'm sure that you should come out on the screen. Even keep your video on and you can answer. If I ask a direct question, any specific motor muscular disorder which can present with the delayed motor part, may not be even the other parts may be obvious, that speech may be normal, personal social normal. I think everybody is putting on the chat box.
And
Yes, Dr. Hardi. I think Hardi was also last time. Come on. I think whether they are on the viewers link or the panelist link on the screen, I'm not sure because their names are not seen. I think you should join this panelist link, come on the screen and answer. Okay. Malnutrition can be there. DMD can be there. Very good. Please remember some of the points of development because it is going to be the very common question, common discussion in the exam. Anyway, I think let us go wait for some time. We'll go in the developmental list in details. And second thing, what he has said, the tightness of the limbs. So what does it indicate? Any other student before Akshat speaks? Because Akshat must have come with some preparation. Any other student? Tightness of limbs. Some of parents are not there. Dr. Ujjwal, what will be your interpretation? Yes, somebody is putting Abhiram, increase in the tone. Yes. Maybe we can say that it's very clearly to indicate the spasticity. Right. And then you can try to define whether it's upper limb, lower limb. Anyway, but what we decided that here the 12 years old boy has presented mainly with the delayed development, which mother has noticed since early childhood, and even the tightness of limbs. Likely we understand that may be the spasticity. Now let us try to understand details of the history which will provide more information. Akshat, you can take it further. You can share your PPT and take the history further. I will request Dr. Kiran and Dr. Trupti, being teacher, you can identify some of your students. You can motivate them so that they can participate in the discussion. Yes, Akshat, you can take it.
Like in first trimester, she was registered in nearby PHC. No history of excessive vomiting, no history of fever and rash, no history of any drug intake, no history of radiation exposure, and no history of gestation diabetes mellitus, PIH, seizures, or thyroid disorder. Um, Iron and folic acid supplementation was not taken till the end of first trimester, and USG was done at the end of first trimester, which was within normal limit. In second trimester, tetanus oxide 2 doses were given, and no history of fever. Iron folate tablets were started taken from 4.5 months of gestation, and quickening fed at around 5 months. No history of trauma, no history of drug intake, no history of foul-smelling vaginal discharge, and no history of UTI, PIH, or seizures. At the end of at the mid or the end of second trimester, USG was done, which was also within normal limits. In third trimester, no history suggestive of malpresentation, and no history of bleeding, no history of fever, rash, UTI, or discharge or constipation. No, and at the end of at, in the later part of third trimester, mother's weight was 68 kg, and USG was last USG was done 2 weeks prior to delivery, which was also normal. And in natal history, normal vaginal delivery, it was a
Anyway,
spontaneous delivery.
Akshat, can you stop sharing for a while? I think we'll go stage wise so that we can understand. Right. I think this is going to be the very common question that being pediatrician, what we are expecting in each trimester, particularly from the well-being of the fetus point of view. And therefore, these type of the points we should know. Who will take that what you will do or what you will assess, being the pediatrician, being the neonatologist in the first trimester? Who will take it? Please, anybody voluntary should take. Yes, Dr. Ishwarya, I think she was there. In the first trimester,
Yes, sir.
any lady present with the pregnancy, then what specific points you would like to note it? Yes, please take it.
Yes, sir. In the first trimester, I would like to ask the history for fever with rash.
Okay.
Any history of any radiological investigations done? Any
Right.
history of abortions that had occurred previously during the first trimester in last pregnancy? Also, any history related to PV leaks or PV bleeds?
Okay. Very good. Ashwara, can you make your video on, if you don't mind?
Yes.
I think then you know that with that we can have a good discussion with the face presentation, because it in the exam it is going to be there. Very nicely you mentioned, but you know the first always we'll have to confirm the pregnancy.
Yes.
What that lady feels, there are some conditions where she may feel pregnancy but may not be the real pregnancy. Suppose amenorrhea, but amenorrhea can be to the several regions. So that's number very important, that first pregnancy. Second, even you can confirm whether it is the twins pregnancy, multiple pregnancy or not. They can also be confirmed. may not be by, I will say, simple examination, but always you go for the ultrasound examination, and you would like to know even then during first, I will say, trimester also you can do. Second, you said abortions. Okay, suppose if there is a history of multiple abortions, what conditions will come to your mind? Some other lady has presented to you that yes, she lost 2 or 3 conceptions in the past with different stages of pregnancies as abortions. Then which condition, being pediatrician, you will keep in mind?
Sir, first will be torch group of infections.
Okay, which
Second,
which particular torch? You know, that is another thing. Another thing. Don't answer always blanket covering. We'd answer very precisely. Every probably congenital infection may not present with the repeated abortions. So which one? Any idea?
sir,
Sorry.
rubella can present.
Okay.
Even sir, toxoplasmosis also can present with.
Okay. Please remember, very important from the infections point of view, congenital syphilis. Congenital syphilis will come first to our mind with the repeated abortions. Like that, always think in this way, that some of the illnesses related to the mother, some of the even related to the congenital infections. So in that way, you can divide. Suppose congenital infections point of view, thought that yes, congenital syphilis can do. But you know, some of the maternal illnesses can also present in this way. Even simple diabetes mellitus, antiphospholipid emergence, this syndrome. So many even presentations can be there. Sometimes simply even the, I think incompetent hours may not be the first trimester, later on, but that can also be a simple mechanical problem. Right. So what I mean to say that various illnesses should be kept in mind with these abortions. Okay, but fairly good that in the always the first trimester, you will note the age of the mother, advanced primary, elderly primary, what we say, or even the very young mother, then also some of the problems are expected. Then even the very rightly Dr. Akshat mentioned, interval between the marriage and this active marriage life and even this conception, so that you can have the idea. Suppose, Aishwarya, if I ask one more question, some lady has taken the treatment for infertility and now she has conceived. Is there any factor, any risk factor or any problem which you can keep in mind? Any idea?
IVF pregnancies may lead to twin pregnancies, which will
Okay.
be
And then
identified with
you know that the multiple pregnancies, then twins or even further, it is going to be have the more problems. Anything else? Any other problem which is expected with the treatment with the infertility? You know, commonly, usually they are premature also. And therefore, problems related to the prematurity, right? So some of the points, even, you know, some of the drugs which they have taken. So all the things we can keep in mind. Anyway, I will say, I will appreciate your responses that what as a pediatrician we should know. We should always try to know the blood group of the mother. Many times it is based, which I have seen in the case sheet, and later on we come to know. So that's very important. Who will take the second trimester? That as a pediatrician, now what you will check, and very rightly Aishwarya mentioned fever, rash, because all of us know that various congenital infections, we can predict if it was history was there. Okay? Aishwarya, you can identify your colleague. Who is there on the screen? Akshat, who can answer this second part or second trimester of the pregnancy? Don't hesitate. He or she will not fight with you. Anybody? I think Dr. Ria, which names at least I'm able to see, just I'm calling, and I hope that they can join. Anyway, Akshat, what you will check in the second trimester?
So second trimester, most important, most important is anomaly scan.
Okay.
And
And for that,
And-
what specific I will say test or investigations you do?
in anomaly scans, there should
Okay.
be
What is
level two
what is the
level
right
two
time for the anomaly scan?
It is for 18 to 22 weeks, sir.
Okay. Anybody will answer me that why we have selected this 18 to 20 weeks? Which one? Dr. Which one? Or Dr. Nisha? Anybody? Why we go particularly anomaly scan screening at 18 to 20 weeks time? What is the idea? Anybody? Dr. Amisha? Here it is, I wonder that why they don't want to participate in, I will say, discussion. What is their hesitation? Suppose if you are wrong, okay, you can be wrong, no problem. Yes, Ujjwal, come on. I think at least you have
Sir, I think
you have made your video on. That's good. Let me appreciate. Yes,
sir,
come on.
I think to check the fetal structural part,
Right.
then whether to continue pregnancy or should we have to terminate pregnancy, the decision should be made accordingly, sir.
Very good. Ujjwal, what is the, I will say, law in our country which permits the termination of pregnancy optimum time?
Sir, at
Up to
what
what I will say advanced pregnancy law allows you for the termination of pregnancy?
sir, I think 28
Any
weeks. Sir.
idea? Okay, 28 weeks is, I will say, quite advanced pregnancy. Anybody else? Anybody having idea? In our country, due to some medical cause, up to what age you can go for termination of pregnancy? If you are knowing this answer, it helps a lot. Yes, Dr. Ruchika Saini has mentioned 24 weeks. Anybody else? Akshat, you have any idea? Yes.
That is 24 weeks.
Dr.
If there is
Sateja
a
has
loss in
mentioned 20 weeks. Yes, Akshat, what is your response?
It is 20 weeks only, sir. But if there is a gross congenital anomaly to the fetus and it is not compatible with life, we can terminate it till 24 weeks.
Very good, very good. Please, this is the time, number one. First basic principle, we know that most of the organogenesis, embryogenesis, what we say, that is the organ formation, has already taken place by this time, 18 to 20 weeks. All the organs are fully developed. So certainly the gross malformations you can detect. That's a good time to see whether all the organs are developed normally or showing any gross malformation. It's a good time. That is very strong reason why they have selected this time. And almost it is over. Second part, very rightly, I will say Ujjwal answered and Akshat also. That by chance, due to some reason, if the termination of pregnancy is indicated, most of the times routinely, I will say 20 weeks we go, but in certain circumstances, due to really some incompatibility of life for the baby and this malformation, even it allows for the termination at 24 weeks also. So, you know, with selecting some ideas, some points, the time for the anomaly scan is decided, keeping in mind the science of organogenesis and keeping in mind the law, which allows the optimum time for the termination of pregnancy. That's the reason. Anyway, What else you will do during the second trimester of the pregnancy? Anybody else? Anybody? Dr. Vivek, can you answer that during the second trimester of pregnancy, our pediatrician's point of view, what points you will check? Already anomalies can be discussed. And I may not go into the details, but please remember, somebody may ask you, what are the gross or structural malformations which can be detected at 18 to 20 weeks, which you will not miss it. And certain malformations can be missed even. So that I will say it in the fetal medicine, more details is required. I may not go at present in the details, but please keep in mind. Anyway, but what else we can check during the second trimester?
Congenital heart disease.
Okay, Vas. Anything else? Dr. Vivek, you are muted. Unmute yourself. Yes, Dr. Ruchika, just I will say putting on the chat box. She is not coming on chat box. Sorry, screen. Anenchyphalias, any malformation, keep it. Mainly any structural gross malformation, it is very important to detect during second trimester. But what else beyond that? Just very nicely she mentioned quickening, very important. And then Dr. Vivek, somebody will ask this question. Fetal movement or quickening. Suppose if it decrease, mother says. She the experienced mother and reliable, her interpretation. If there is a decreased fetal movement, what does it indicate? In the second trimester, I am asking. Does it suggest anything? Constantly, several times, mother has noticed, that is her observation, and she is experienced mother, reliable her information. Then which conditions may present with a decreased movement? What is my direct question?
Sir, anencephaly can present like that.
Okay, why anencephaly will be present with the decreased movement?
Sir, brain developments are affected, sir.
I think your logic is right, but usually does not happen so. I can't say totally wrong, but something else. Yes.
Sir, uteroplacental insufficiency.
Yes, she had mentioned neuromuscular disorder, Dr. Satya, I think he or she, Dr. Srishti, yes. Which myopathy? Dr. Srishti, which myopathy? We will have to remember very specific common cause in the exam. So that what happens, your answer is clear, there will be no further discussion, time can be saved. Yes, Dr. Sonali has mentioned SMA, spinal muscular dystrophy, It's very common that the mother will notice the decreased movement. Similarly, some increased movement. Some people call it as the fetal seizures. Which condition may present like this? And nowadays, even during antenatal period also, fetal medicine is advanced. Even they can detect, they can confirm, suppose they are suspected. What is that condition? Which presents as increased fetal movements. Many people call it as the fetal seizures. Srishti, seizures as what? Which condition can present? Any condition which we call it
odd compression may present like this.
Akshat, you can, I will say, logically you can think, but it's not so. That hypoxemia is a different story. That particularly will be there in the biophysical profile scoring, right?
Hypocalcemia.
Not hypoglycemia or hypocalcemia. There.
Fetal hypoxia, sir.
Please remember, during this time, all these metabolic problems which you are thinking, hypoglycemia, hypocalcemia, hypoxemia, usually they don't develop during this stage. because through the placenta, it is managed unless there is some problem of gross maternal illness or placental problem. In a normal pregnancy, what I mean to say, problem related to the fetus. Problem is not related to the maternal cause or placental cause. That means increased fetal activity or fetal seizures, what we call, is due to the fetal cause. Cause is related with the fetus. Let me give you some idea. Srishti, I think you can think further. That condition is related to some vitamin. Yes. Now Srishti has put it. There is pyridoxine dependency, deficiency or dependency, what we say. That can present with this fetal seizure. Please, in the exam, when you have the good performance, these type of questions are going to be there. And not so common, but yes, they present. So during second trimester, you will see this placental location, that is very important. You will see the fetus, malformations and everything. Very important, you will check again whether the blood group of a mother is confirmed. You will start you on tetanus toxoid. He said TT 2 doses. Srishti, is it right? What we offer to the mother at present during pregnancy, whether simple tetanus toxoid is available. You can check in your hospital. Vivek, I think Dr. Divyanshu has put something else. TAD, what is TAD? Yeah, corrected. TD. Srishti, my question will be different to you. Unmute yourself. I hope that you will try to answer. Dr. Pranay said TD is given. You know, general hospitals, we give the TD. But suppose some known or some person from your family, that lady is pregnant and she has gone to her obstetrician. Rather than TD, he has advised something else. And now she wants to confirm whether should I take it. Okay, Dr. Ujjwal has responded. Dr. Ujjwal, you can speak, please. Don't put on the chat box. I want to make you speak. You should speak. He has put the TDAP. What is that TDAP? Srishti, any idea what is that TDAP? Unmute yourself, please.
Yes, sir.
Come on. Srishti, that lady is advised the TDAP, Ujjwal says. Now she's known to you and she's asking you, should I go for the TDAP during my pregnancy, second trimester, and obstetrician advice? What you will now suggest to her? Yes, Dr. Divyanshu, what will you do? Please, I will ask you the most practical question. And same question are going to be discussed in the exam also. Vivek, what you will do? What is that TDAP? And whether the obstetrician advised rightly? Srishti, yes, what is your response?
Sir, TDAP is tetanus, diphtheria, and acellular pertussis.
Right.
So that is given for booster dose in adults.
No, sister, my question is very clear.
Yes, sir.
Your known person, or suppose somebody is asking you that I am advised by the obstetrician during my pregnancy TDAP, should I go or not? What you will advise? What you will suggest?
So can be used.
And then whatever your answer is there, you will have to give the justification. Yes or no. For yes also justify, for no also justify. You said may be given. Why may be given?
Can be used.
You know, in the exam also never answer in this way. Yeah, with is very clarity, clear answer. Yes or no. What? How you will? I will say the reply to your relative. May be given. Then how she can decide?
Yes, sir. But it is a costly vaccine. But can
she's money is not the problem for her. She said that don't worry
so
about the money.
We can use TDAP.
Why we are using that? Why we are advising?
So because there is acellular pertussis and it is safer to use acellular
But
pertussis.
why? Usually we don't give. We give the only TD in the
The
government hospitals.
neurological complication to prevent neurological.
This is the question why that every pediatrician should know. Purposefully, I'm asking the question. Best, very rightly, Srishti advised. If you are able to manage, best advice is TDAP. By Bustric's name, the vaccine is available. Because of its cost, as you said, it is not in our government program. But in government program also, T small d is there. At least diphtheria, we are able to do it. Pertussis, why? Because you know that for the pertussis, newborns don't have the antibodies from the mother. And suppose by chance the newborn develops the pertussis, you must be knowing it is very serious disease. Problem, complication rate and mortality is high. So you want to protect that baby, you give this TDAP to the mother so that pertussis component will transfer even the antibodies to the baby and baby is getting the protection till you give the vaccine at 6 weeks. Am I right? Again, in 6 weeks, you are going to give the vaccine. So that's why I want that most practical answer should be known to us. Routinely, we go to the TD, TDAP, and use the minimum 2 doses. Last dose 15 days before the pregnancy is expected. It's a good time. And suppose if you feel that mother may not come at that time, you can give in between at any time. But at least the 2 doses should be given. I think many questions can be asked in this aspect also practical, so you should know. Suppose some mother is very educated, that young lady is educated, or even from such a family, that she received 3 primary, 2 boosters, particularly 1.5, anybody 5 years, so total 5 doses. She was given 10 years and even 16 years. So 7 doses tetanus she received before she reached to the stage of pregnancy. Srishti, now my question is, what will you advise to this lady? She will say, I have taken 7 doses of tetanus. Even she will show her card. Then you can see the 3 primary. My parents were very careful. And they have taken the 3 primary, 2 boosters, later on 10 and 16 years. So total 7 doses.
So if it is not taken within 10 years of conception, then we have to.
Srishti, my question is very clear, I think. Right, 16 years, last dose she has taken.
Yes, sir.
And suppose now she is 23 or 24 and she is pregnant. Now what you will advise?
So I will advise to take the 2 doses.
Okay.
PD.
So that is the Srishti's suggestion. Vivek, what you will do? Suppose this lady is known to you and she shows a record even. We are not to just believe. That means documented. What you will advise? Akshat, what you will do?
Booster dose must be given
How
to
many
the lady.
doses? My question is very simple. How many doses?
One dose on this.
Why 1 dose? And which one was 1 dose? TD, TDAP, or TT, which one?
BAF will be TDAP and in subsequent orders TT, then TD, then TDAP. 1 booster dose and in second trimester.
Anyway, please, I request all of you. Recently, we have published, our IEP has published a purple book. Probably all these points are mentioned. And suppose 7 doses of tetanus toxoid received and 1 single dose is sufficient. And again, she comes with the pregnancy within 3 years, there is no need to give the tetanus toxoid. So you should be very, very careful. Anyway, what I mean to say, in the exam, not necessary, they are going to ask you to discuss the condition. They want to know you that how much pediatrics you know. Somebody may take this aspect, somebody may take another aspect, because there are 4 or 6 examiners. Anyway, so second trimester, even the blood group of mother. Again, blood group is another chapter, which somebody will go in the details. Regarding RH incompatibility, ABO incompatibility, so many issues. So you should be well prepared. And what particularly you do during the third trimester? Third trimester, you know that is very important stage. Now probably you will see the growth of the baby. That is very important. And well-being. Well-being of this baby, and for that reason you will assess the baby, assess the placenta. Placental, I will say calcification. Even Doppler, so that perfusion you can come to know. Biophysical profile scoring by the sonography. That is regarding movement of the baby, heart rate, somebody was talking, respiration rate, or even the pockets of amniotic fluid. And there is scoring system, and from that you can decide well-being of the baby and growth of the baby. And for that reason, you can, from the various parameters, you can decide whether the baby is having the neurological head size, what is the expected weight, and whether this weight corresponds to the pregnancy. All the things you will have to see, maturity of the baby. So these are the points which you will assess in the third trimester. And suppose something unfavorable, you'll be prepared. Suppose you are expecting preterm baby, you will go for antenatal steroids. Or suppose the baby is almost towards the term, not full term, but towards the term, and there is some hypoxemia, intrauterine growth is restricted, better to take these babies early outside, so that problems and complications can be minimized. So all the points are very, very important, that what you will do during the pregnancy. And being particularly, nowadays, I will say consultation by the pediatrician or neonatologist, involvement is from the conception. And our role should be there for so many things, in order of metabolism, malformations, fetal well-being, growth, and steroids, then even the blood group incompatibility, intrauterine infections, even mother develops, suppose something, chickenpox during pregnancy, or even the diabetes mellitus, all the points we should know. Anyway, this is just to sensitize all of you that all these aspects should be known to you. Akshat, now you can take the history part further.
Yes. In
Yes, please.
natal history, there was a normal vaginal delivery. It was a spontaneous delivery, institutional delivery in a private hospital. She remembers that 8 months and 15 days were passed till that date. And baby was born preterm, normal vaginal delivery. Birth weight was 2 kg and a male child. Baby didn't cry immediately after birth. Resuscitation was done with oxygen support, and according to mother, baby had abnormal upper and lower limb movement inside the labor room itself with Lewis discoloration. Then he was transferred to NICU. In NICU, there was a stay of 21 days. On day one, baby had convulsion, received IV medications. Urine stools were passed within 24 hours, and O2 support was given along with IV fluid and IV antibiotics. And on day two, developed seizures and further IV medications received. Day three, baby was shifted to government hospital in ICU because of financial problem. And day five, feeding was started by NGT. EBM was given 3 hourly. On day seven, developed neonatal hyperbilirubinemia, treated with phototherapy. And on day 12, started on Vati spoon feeding with express breast milk. Day 19, sucking developed, and parents were informed about abnormal neuroimaging. On day 21, Bay was discharged from NICU on anti-epileptic drugs, on anti-epileptic drug phenobarbital and supplements, and follow-up was advised. Mother was trained regarding baby care, feeding, and physiotherapy. Weight at discharge was 2.4 kg. at home. At home, child remains lethargic, but taking feeds well and passing urine and stool well. Regular follow-up at time in GMC, Solapur, and ICU. Weight gain was present. Good compliance on medications. No respiratory problems till then. Mother noticed that child is not developing as compared to his age-dated children, and also having tightness of all four limbs. Uh, and no recurrence of seizures till 3 years of age. Child was admitted for seizures at 3 years and 4.5 years, which was both the times that seizure was diagnosed to be breakthrough seizure. And seizure lasted for 1 to 2 hours. A GTCS with the problem of eyes with post-ictal drowsiness, and he received IV medication. No history of triggering factors like fever, trauma, cyanosis, or vaccination. Further, there's no history of new onset focal neurological deficit, weakness, or regression of milestones. Patient had last episode of GTCS at 4.5 years of age. Currently, he has seizures free from 4.5 years of age. So 7.5 years have been passed since the last seizure episode. On inquiring, she mentioned that child did not attain neck holding till 1.5 year of age. She also said that child did not had social smile at 2 years of age and started recognizing his mother at 2.5 years of age. When baby was lifted up hands by hands under his arms, he used to tighten all his forelimbs. Rolling over was presented at 2 years of age, sitting with support at 3 years of age. He had alertness to sound at 4 years of age and started cooing at 5.5 years of age, and laugh aloud at 6 years of age. She also added that the child had recurrent cough episode and dribbling of saliva from the mouth. There is a history of recurrent episode of URTI for which he got there are recurrent episodes of LRTI also, and for which he got admitted several times, where nebulization and antibiotics were given. She also told that child had difficulty in passing his stools, received laxatives many times, and he perceives pressure, touch, and pain sensation. He also has a bad sore over back or at the scapular region. At present, he can sit with support at the corner of the room and smiles on stimulation, recognizes his mother. He is not started with any physiotherapy by the caregivers. No history of involuntary movements, no history of abnormal deviation of the angle of mouth or facial asymmetry. There's no history of there's history of difficulty in swallowing of food, and mother gives him a mashed or semi-solid food. But in family history, the Arman is first born male child of the family, born out of non-consanguineous marriage, and there are no similar complaints in the family. Developmental history, gross motor neck folding achieved at 1.5 years
I
of
think
age.
again, can you stop sharing for a while? Because whatever you have discussed, let us try to understand. Then we'll focus on the development. Yes. I think from the history, what Dr. Akshat described, particularly at the time of birth, I think that was 3 weeks time for the NICU admission, Dr. Akshat, am I right?
Yes, sir.
Yeah, 21 days, 3 weeks aside, with all the events, what he described. Dr. Srishti, when you are discharging such a baby, Srishti, are you there?
Yes, sir. Yes, sir.
Suppose such a baby, I think you attended what Akshat had described.
Yes, sir.
In the NICU from even the for 21 days admission and everything. Now suppose you are discharging this baby. What will you give the guardian prognosis to the mother? Because mother will ask this question. On supposable, if she does not ask it, our duty to explain her. But she is going to ask that now, should I expect any problem to my baby, or is going to be all right in the due course of time?
Yes, sir.
So what will be your idea? How will you explain or counsel
Since
regarding prognosis?
Yes, sir. Since there is long stay, this newborn is a high risk newborn. So I will have to explain it to the mother that there can be food aspiration, while feeding, she has to be very careful for feeding aspirations. So there should be prolonged burping and baby should be in upright posture while
No,
feeding.
sister, my question is something different. You are right, what you are describing, but I want to know from you something else. That what you are expecting in this baby in the future.
So since
Is it going to be, suppose, normal or having some problem, or what problems, and how you are predicting? From which background you can say that this is your understanding, this is your prediction?
yes, sir. Since there is event of seizures is there, so I can think of there is some cerebral.
Sister, before that, anything else? Before seizures, anything? The always describing chronology, so that it become the impressive for you, even for understanding and for examiner also. I think before seizure, what problem developed with the child at the time of birth?
So, delayed cry was there.
Yeah.
Baby did not cry immediately.
Did not cry. So it's a major event. It's a major event, right? Because you can say it was a hypoxic ischemic encephalopathy. Now, before that, even I would like to know from you, suppose due to some baby cry or didn't cry or this kind of some history, how will you predict that whether the encephalopathy was developed with this baby or not? Every baby will not be having the worst picture of even the seizures and everything. So from which type of your observations you can predict that yes, this is the encephalopathy and likely due to the hypoxemia?
So at the time of birth, if baby is having excessive cry or irritable cry, there could have been an insult which made the baby to cry.
Very good, very good. You know, irritability, constant cry.
Yes, sir.
Mother is or your nursing staff is informing that, madam, after this delivery, the baby was in a nice way. Anything else opposite to that constant or irritability or crying? Maybe sometimes
the decreased activity and
lethargy. Yeah.
Yes, sir.
On the contrary, baby is not crying at all, which normally you are expecting.
Yes.
So any lethargy, not crying,
decreased activity,
or
lethargy,
even irritability, constant crying, right? This thing. Then what happens? You know, after birth, what the mother will try to give the breast. So what happens in the breastfeeding with the encephalopathy?
Not able to suck.
Yeah, this. So think, I will say methodologically, chronology, you will never forget that there was a history of didn't cry. It requires some resuscitation. That also you can know that up to whatever resuscitation was required. That will give the idea of even some severity, grade of the hypoxemic encephalopathy, right? Whether just use stimulation, or whether it required this Beg mask resuscitation, or whether it required further ventilation. All this will give the degree of problem or expecting brain damage. And then later on, as you said, activity, lethargic, excessive crying, somebody mentioned abnormal movements. Yes, that is very important. Very rightly said, feeding problem, not taking foods at all, or even seizures now you say.
Yes, sir.
You know, from all these points, even this suppose required the ventilatory support, prolonged oxygen therapy, even suppose by chance some babies develop even the infection, meningitis also. Some babies develop even the sepsis also. Some babies develop even hypoglycemia. You know, hypoglycemia will also cause the damage to the brain.
Yes, sir.
So even the some baby, I think here he said maybe require the phototherapy for hyperbilirubinemia. That also we'll have to know that what level of hyperbilirubinemia. That can also cause the further damage to the brain. So what I mean to say, Srishti, all of you are knowing these points, but I want to bring to your notice. In the exam put on the paper, suppose this of the presentation is there, you can say that all these factors were present in this baby. And then I am expecting that there is some brain damage. Always we are predicting, expecting, not necessarily it is always there. In spite of your worst situation, baby may be good sometimes. And with the mild history, baby is having the major damage. So difficult to explain that, but at least we can predict, we can suspect. And on this ground, you know, very nicely we can explain. So when you are talking to the mother, you can say that you know that this baby, suppose it was the preterm, I think it's a good thing again to explain, because preterm babies are going to be more problem. Suppose preterm baby, IVGR baby, I think here both the factors were there. So you can say that you understand that your pregnancy was fairly good up to this time. But at the time of delivery, unfortunately, we have faced the problem. We know that as soon as the baby is out, baby should cry. With the cry, respiration starts, and baby gets oxygen, and then the whole life starts. But due to this unfortunate event, suppose baby didn't cry immediately for that time, respiration was not established. That's why hypoxemia developed. And brain is a very sensitive organ in our body, responding to the hypoxemia. And it was of so degree that due to the prematurity or hypoxia, therefore baby developed this problem at a time of birth. So we are expecting some damage to the brain. We are expecting, may not develop. Having again, you know that the baby required a 21 days NICU admission. That means some problems were going on. Maybe they were seizures, maybe the hypoglycemia, maybe the jaundice. And due to all the issues, now fortunately we are out. Baby is fairly in the good condition. We are discharging you today. I will explain you the details of the regular follow-up, even how you should take the care. But just I would like to say a word of precaution to you in anticipation that this baby we are not sure will be totally normal or having some sequelae or problem or complication in the future. Having this, I will say this type of the background, I'm expecting that there may be some issues. And suppose by grace of God, if we don't face, we'll be happy. You know, this will be our, I will say, way of explanation. We are always giving the guide. And you know, by this, suppose if you're discharged, the state the patient comes back with some problems, mother knows that, yes, madam, you talked to all these issues. Now I'm facing the problem. So they develop the confidence with you, lesser the, I will say, issues with us, and even they mentally they'll be prepared. So, and again, you know, in the exam now, most of the examiners ask you that how will you counsel? How will you talk to the parents? In any case, these have the chronic problem or issue. And that was my idea, that let me sensitize all these students that in this, any condition, not necessarily only nephrotic syndrome or even bronchial asthma, they are going to ask you that how you are going to talk to them in the details. And all of us students, I will say not only exam point of view, daily practice will do, our parents will be happy, right? And even we also feel that we are doing what is recommended by the science. So that is to be done, right? So you can find out the factors, problems with this history or examination, that were problems. And in our patient, Akshat described not many things with the problem, right? So that was the idea, Akshat, to give the, now you can focus on the development. You know, still we are discussing only history part, Akshat. More than almost one, I will say 1 hour and 15 minutes. But I'm sure that at the end of history will be very clear. Please complete the history now.
Developmental history. Gross motor neck holding was achieved at 1.5 years of age. So developmental quotient will be 16%. Rollover achieved at 2 years of age. So it will be also 16%. And sitting with support was achieved at 3 years of age. So DQ will be 16%. So the average DQ for gross motor will be 16%. In fine motor, child till now child has not achieved any fine motor milestone, so DQ will be 0%. In language, going at 5.5 years, and laugh aloud at 6 years, so that will be 5%. So DQ will be 4%. In social smile, baby develops social smile at 2 years of age, so DQ will be 12%, and mother the guide at 3.5 years, so 7%, and the average DQ of social will be 10%. In past history, last admission was 8 months back for constipation and LRTI in civil hospital. Anthropometry wise for weight for age observed is 14.5 kg and expected for the age of this child is 39 kgs. So 37% is achieved till now, and grade is grade 3. And height for age, he is 128 centimeter, and expected height is 148 centimeter. 86.5% is achieved, and grade 2 moderate stunting is there. Head circumference is 43 centimeter, and US ratio is 1:1. And the BMI is 8.9 kg per meter square. So it is within less than 5th percentile. So severe wasting is there. Severe wasting is there. And so interference of anthropometry is a microcephaly with severe wasting and moderate stunting. In dietary history, by 24-hour recall method, calorie intake, required calories for calorie for this age is 2190 kilocalorie per day. Actual intake is 1120 kilocalorie per day, and deficit is of 48.8%. And same as for protein intake, required protein is 40 grams per day, and actual intake is 13.1 grams per day. So there is a deficit of 26.9 grams or 67.2%. And socioeconomic history, the total number of family members are 6.
I think
Head of family is
Akshat, you
father.
can mention the interpretation to save the time.
Yes. The family belongs to a lower socioeconomic class according to modified Kuppuswamy scale.
Because in a case of
Immunization-
malnutrition, somebody will go in details of all the dietary history and even the socio-economic status of the family. So at some other time we'll focus at present on the whatever the issue is there. Okay, next.
Immunization history, baby is immunized till date, and BCS card is present over left arm. And general examination, patient is conscious, active, and alert.
Anyway, can you
yeah.
stop sharing for a while? Just we'll take, I will say, a few minutes for the history part, and then we'll wind up from the history. Please focus on the developmental history. That is very important. Second thing, anthropometry should be taken in examination because you are going to measure. Am I right? And therefore,
Right.
always that should be taken in the examination. Second point, have you taken the height of this patient or how did you measure? Because child may not be able to stand. Am I right? Akshat?
By a flexible tape, I have measured upper segment and lower segment. So.
Yeah, that means you must have measured the length.
Yes.
So always because
Maybe
in this
child is not able to stand.
Yeah, that's why even in the exam, don't give the space to the examiner. Again, some of your time will be wasted. So when you are presenting, you can say that it was not possible that the child was able to stand. So height is not measured. But I have taken the length. And you can take the length and then even upper segment, lower segment, or you can make the summation. Somebody is again here going to discuss the difference between height and length. Whether height will be more or length will be more in a normal person. Suppose 5 years old child, you are taking the height. Child is able to stand 5 years. And if you are taking the length, so what will be more, length or height? And why? And what is the difference? Please remember, in such patients, you will not be able to take the height and therefore length. And the length is going to be more compared to the height, even normal person. Because in standing position, there is some compression of this vertebrae. And therefore, compared to the length, height is going to be less. Second thing always, the difference also you should know. Here, I think in this patient, there is no question. Now focus regarding the development. Please always remember, development is very important aspect for the pediatrician. Very important. I will say it's a super specialty for the pediatrician. Even child is brought to you for any minor problem, assess the development. And if there is some problem, you can make out. Second thing, development is always cephalocaudal. That means first the head control, then the rolling over, then the sitting, then standing and walking. The sequence is going to be the same. There may be some physiological variation, but sequence is not going to be changed. Second thing, always from this assessment, history, and even your examination, decide the development and ask the question, is it normal or abnormal? Suppose if it is abnormal, ask the questions to yourself. What is abnormality? It can be delayed development. It can be the regression of milestones. Right, so that you can decide. Regression, you know that already there is loss of the achieved milestone. There is regression. Very classical example we can see in our daily practice, infantile tremor syndrome, or even CNS degenerative various disorders. There is a regression of milestone. Delayed development again decide whether all the 4 milestones are equally affected or differently. Some conditions, suppose malnutrition, already what we are discussing, DMD, motor part is more affected. While personal, social, language may be less affected or may be normal. Autism-like condition, gross motor, fine motor is normal. But speech is delayed, personal, social is delayed. So that type of if you can decide, and suppose more than 2 domains of the milestones are affected, we call it the global delayed development or isolated delayed development. Once you decide global delayed development, then you decide whether it is a dissociation or a deviation. Dissociation, that means some conditions, motor milestone, gross motor is more affected, some conditions, speech is more affected. That is the dissociation. Deviation, that means some milestones develops in advance. Suppose hand preference before the age of 1 year. Child is even walking on toes early. This advanced milestone, that is the deviation. And that may be the early sign of cerebral palsy. So whenever this, I will say, problem of development is there, we can decide. Second, development quotient is a plain figure. It is not the percentage. Commonly, every student mentions percentage because 100 comes multiplied by 100, but it's not the percentage. It is always plain figure. Second, always in the development, please remember that sitting does not develop by 2 years. Probably prognosis is not good. It is said that any child who is not able to sit up to the age of 2 years, you can predict the prognosis that more than 90% children, prognosis is going to be poor. And if the child starts to sit even before the age of 2 years, with your further management, physiotherapy and all the management, there is good or expected response is going to be there. So I think these are the few points which we should expect. Another exercise, people are going to ask you summary regarding this patient, and always give the summary in the form of the I will say hypothesis, what you understood. Don't go for the repetition. I want at least 1 or 2 students to give the summary in this patient. Anybody can try? Dr. Vivek? Even Abhiram was also active. Srishti? Please try to give the summary, Vivek. How will you summarize the history part in our patient? And it should not be the repetition. Please give very small, I will say 8 to 10 lines.
Sir, the patient didn't cry immediately, sir.
Right.
And so after that, patient was admitted to NICU, and on day 2 and 3, patient had a hyperbilirubinemia episode for which phototherapy was started.
Right.
Gradually, patient was started on NGT feeds and all. And gradually, when the patient was able to suck, then he was started on party spoon feeding. And
Very
after
good.
adequate weight gains, the patient was then discharged, and the mother was counseled regarding the probable developmental delay which can be seen in the future, and she needs regular follow-up for that. Um,
Very
patient
good.
might
But what is your conclusion that what has happened to this child? Can you
that the
predict?
yes, sir. Sir, as the patient had an episode of convulsion, so probably the patient is in hypoxic and hypoxic ischemic encephalopathy with that can with convulsions. Patient is in stage 2 of HIE, um, uh,
Right.
and the patient has suffered brain damage, which is showing as a developmental delay, as the mother is concerned regarding not able to achieve the milestones at the age of 2 years.
Right. Yeah. I think, always try to think in this way for the summary. That what is the anatomy? Suppose CNS here, which part of the CN, nervous system? It is central nervous system or periphery? In central nervous system also, which part of the brain is likely affected? Try to think. From the history, we have fairly good information. Second part, try to answer that what is the likely pathology, pathophysiology. It is congenital, it is traumatic, it is vascular, it is hypoxic, it is hypoglycemic, if it is hyperbilirubinemia, it is the regression, there is degenerative disorder, it is autoimmune disorder, vascular, so many things you can predict from the history. And then try to answer possibilityology. This is a very good summary. Srishti, would you like to make one attempt in your own way?
Yes, sir. So this is a 12-year-old child with history of NICU stay, delayed cry, and history of seizures, which have also recurred twice. And there is history of global developmental delay. Currently, there is also mother has noticed that there is stiffening of bilateral limbs. So overall presentation is of cerebral palsy. And because of natal insult, which has happened during the birth. So, from localization, I would like to say that this is central nervous system, CNS, not peripheral, since there is global developmental delay and there is spasticity, as the mother is describing in the bilateral lower limbs. So there is some upper motor neuron lesion.
Right. Good attempt. I will appreciate both of you. I think my efforts are successful, not failed. Then at least some students have come, they have started to speak, they are responding. And on the contrary, very nicely, I will say you're responding. Your responses are good. Please, I request you that continue to speak for learning. My attempts, actually, I'm trying to motivate you because I know that unless we speak, we cannot learn. You may be knowing, but for expression should be there. We should be able to speak. Anyway, very simply, I will try to give the summary. You can say that Dr. Akshat had brought the 12 years old boy, and which significant or chief complaint is the delayed development and spasticity of the limbs. While going into detail of the history, somehow first, second, or third trimester pregnancy period was uneventful. That means no history of fever, radiation, infection, all the things in one sentence I say. The pregnancy period was uneventful. The problem happened at the time of birth. And from the history, it is very evident that it was hypoxic ischemic encephalopathy. Very significant grade, whether you call it a grade 2 or grade 3, but I think grade 3. That gives the severity. And having this, if I try to think for the lesion, it's a gross, diffuse cortical lesion. It's a diffuse, even gross cortical lesion. And pathophysiology, already which I stated, is a part of the hypoxic ischemic encephalopathy and related events. Related events in the form of the NICU admission, ventilatory, hypoxic, even the seizures, feeding problems, all these are the issues in one line I answer related to the hypoxic ischemic encephalopathy and its sequelae. And etiology quite obvious, that baby didn't cry. Sure, I think you know that it reflects our obstetric services. That's very important for our learning, which are not going to discuss with the parents, but for our understanding that this part requires some, because that lady were under the care of the obstetric from the first trimester. And once you know, it becomes our duty to monitor them and to guide them properly. Anyway, I think this was a good history part. Let us now, Akshat. Even you know, sometimes, Srishti, some examiner may ask you, if I am your examiner probably, I will ask the question in this way, that what you are expecting on examination of this patient. Suppose I have not seen the patient, right? I'm sure that probably you have also not seen the patient. Then what you are expecting on examination, that you can predict having this history. And please remember, in the neurology, it is said, I will say as our any system, but in neurology, 80% diagnosis will be obvious from good history. Rest of the part on examination, I will confirm my finding. And investigations for confirmation, documentation. Investigations is not for anything else. My diagnosis is going to be clear from history and examination. If I just state that what can predict in such a case, I will say what this type of the 12 years old boy with this type of the development, the child is totally, I will say, dependent. May not be in good shape, particularly from the position, posture, nutrition, everything will be having the problem. Maybe having the spasticity and therefore deformities, contractures, bell sores. Likely, if it is not there, but I would like to check. The nutritional problems, so many. Because nutrition will not be the good. We cannot provide. So that is one aspect. Second, further, even hygiene, naturally, very difficult for any parents to maintain the good hygiene. And therefore, due to the bad hygiene, even lot many skin problems and issues can be there. Even many times we are not sure about dystonia or something, sometimes even the problems, even the particular rickets is very common in these babies. Because babies are not having the sun exposure, nutritional problem, even suppose seizures, must be some anti-epileptic drugs. Anti-epileptic drugs can also cause the problem, vitamin D deficiency, you must be knowing phenobarbital, phenytoin, or even so many drugs. Valproate can also cause it. Therefore, the deficiency, even the constipation is going to be there in these patients. Aspirations and therefore respiratory, even the infections are going to be very common. Neurological point of view, development is very poor, right? And therefore spasticity, even some deformities, contractures. I'm not sure, but suppose the bulbar palsy, then drooling of saliva, even the nutrition, oral hygiene. So, you know, all the things we are expecting. Now let us check and see that what is there in our patient. Akshat, now your job is very easy. You can describe this examination.
All right, sir. General examination. Patient is conscious, active, and alert. Heart rate is 78 per minute. Pulse is regular in good in volume, no specific character. No radial or radiofemoral delay. BP is 100/70, measured in left upper limb and left upper arm.
Akshat, sorry for interruption. But whether the patient was able to recognize even the parents?
He is able to recognize his mother and family members only.
Okay, whether the parent, I know 12 years old boy, whether child was aware that where child is in the hospital, at home, or timing or something?
So the awareness component is not there, sir. There's no cognitive ability in the child.
What actually I want to convey, difficult to make a comment that the child is conscious. Because usually what we define the consciousness. Consciousness, that means awareness regarding internal as well as external milieu. External milieu, that means regarding its own status, its recognition, timing, person, known, unknown, 12 years old boy, so many things. I'm sure that this boy would not be able to do all the things. Therefore, difficult to make the comment of the consciousness, right? Because it will invite a trouble in the exam. Okay, probably child may be little bit active, may not be even the total alert. Suppose if you call by the name, child was able to respond to you.
No, sir.
That's why. Normal 12 years old boy is going to respond to you if you call by name. So this child, therefore, this comment, conscious, active and alert, is not properly for this patient, right? So find out the proper things. Many times the discussion happens in this way. Anyway, I will not take much your time. Just I want to draw your attention. Please take it further.
Pallor is noted. No sinuses, no clubbing, no edema or lymphadenopathy, and no odor is there. Built generalized wasting is present. Head size is 43 centimeters. Microcephaly. Face no dysmorphic faces. Dentition, child has mixed dentition with good oral hygiene. Dental caries are present in both last molars. Eyes, pallor noted, mild, and no conjunctival xerosis, ptosis, or nystagmus. Ears are normal. Nose is normal. Oral cavity, there is drooling of saliva, and oral hygiene is maintained. Lips, chest, skin, hair, nails are normal. Bilateral elbow and bilateral knee contractions are present with grade 3 modified as per the criteria, and bilateral thumb adducted grade 2 contraction is there. Bilateral middle and ring finger flexed contraction is present, which is of grade 2, and right grade 2 contraction is present, which is fixed contraction, and left grade 2 and left two first two toes there is a contraction, and a bilateral ankle contraction is present. No neurocutaneous markers are there. No spinal deformity. Bite sore is present over back, over left scapular region, and no involuntary movements can be seen. In system examination, CNS higher mount
Anyway,
child is lying.
just I will say for a few minutes, can you stop the sharing? I want to discuss very specific 2 or 3 points. I will not take more time because I'm looking at our time allotted to us. But 2 or 3 questions, because maybe the good. Dr. Vivek, or even I think Abhiram, can you come out? Vivek, he mentioned the dysmorphism. What is the importance of dysmorphism in this patient?
Sir,
Is it important?
Sir, patient can have a microcephaly with and can have poor development of the brain because of the hypoxia affected in the antenatal during the perinatal period. So patient can have microcephaly and low set ears. So it is
Why
also
low set ears during the birth asphyxia?
no, sir. I'm just mentioning the dysmorphic features, sir. This
No,
it is
what is my question? Okay, I don't want the details of dysmorphism, maybe some dysmorphism, suppose if you are convinced. But my question is, in what way is there any link between the dysmorphism and this type of CNS problem? That's my question.
the patient can have microcephaly in this
Suppose
patient.
my question directly, if I ask you for clarity, not necessarily this is cerebral palsy, this is something else. Then is there any link between the dysmorphism and this type of CNS problem? That's the question.
Yes, sir. Dysmorphic features can be present with the developmental delay, sir. In the start of the discussion, Down syndrome can have a developmental delay. So if the patient has a
But I think Down is
prolonged
different condition, which
microcephaly,
will be obvious. We'll never forget
yes, sir.
it or will not miss it.
Yes, sir.
Anyway, what actually I want from you, suppose if you don't know even in the exam, you can answer. The dysmorphism may be the part of some genetical or chromosomal disorder.
Yes, sir.
Any genetical disorder, any syndromic condition. With some syndrome, dysmorphism is very common.
Yes.
And there are several syndromes that they can have the CNS involvement. If somebody is going to ask you, Srishti, then, can you give some example where dysmorphism and CNS involvement may not be of this, I will say, like cerebral palsy or this severity, may be of different severity. But can you give some example that dysmorphism is there and CNS problem is also there?
Sir, in spine.
Very common. Don't go for uncommon things. Give to very common.
So, sir, in Prader-Willi, there is dysmorphism and there is
Okay.
CNS issues.
My question is, Srishti, have you seen the Prader-Willi?
No, sir.
Yeah. So why unnecessary? It is there, but very common. I think Abhiram is not speaking, but putting on the chat box. He's like Sahadev, that even I will not speak. But you know, the point is very common if I say MPS. I'm sure you must have seen the MPS.
Yes, sir.
Because it is common. And MPS, you know, very obviously dysmorphism features. CNS problem is also there. So like that. Even another condition, if I give the idea, which is just like the cerebral palsy, spasticity, developmental problem, everything, even injuries, marks. But the parents say that up to what certain age, suppose 1.5 or 2 years, child was normal, totally normal. Now develop this problem. 5 years, 6 years child is brought to you. What will be your thought?
Neurodegenerative disorders.
Like? But you know, there is no degeneration.
Regression.
And very specifically ask the question that there is a multiple injury marks over the forehead, multiple sides of the face. In child have the spasticity, child have the contractures. And these parents say, no birth asphyxia, no NICU admission, nothing was there. Even for 1.5 or 2 years, child was fine. SSP will develop at the age of 12 years, later on 8 to 10. But this child is only 3 years, 4 years old. And therefore, many people even diagnose as the cerebral palsy.
The infantile spasms.
The infantile spasm, okay, but that will be the different presentation. Here I said multiple injuries over there. Please remember Leschman syndrome. If you open the book, it's very common. And presents like totally cerebral palsy. It is said that Leschman commonly diagnosed as cerebral palsy by somebody. Then some good neurologist or somebody will think and it will be diagnosed. Genetical testing even can confirm. So dysmorphism can be due to the some conditions, maybe the syndromic, maybe the genetical, and mimicking like cerebral palsy. That's why it is relevant to mention the dysmorphism. Good. Second point, what he said, mentioned, neurokinases marker. Yes, that is also relevant. And why I'm telling you, in the exam, if you want to score, positively mention this point. Even Srishti, I will give the idea, Vivek. Suppose if I am presenter, I am the student, because I want to show my knowledge to the examiner. Even after speaking, take some pause. Ask the examiner, do you want to ask me something? Right. After mentioning about the neurocutaneous disorder or dysmorphism, take some time, I will say a few seconds as the pause. Examiner will understand that, yes, this is a smart candidate. And if even the examiner asks you the 1 or 2 questions and confirm that, yes, okay, Vivek knows, Srishti knows, Akshat has idea. You know, that's the thing that how you can, but you know, with the presence of mind you can do, if you are aware of it. And if you do, you should have the idea, you should have the answer, so that no problems. Another thing he mentioned, Vivek, here, drooling of saliva. What does it indicate? Direct question.
Sir, bulbar palsy.
Very good. Bulbar palsy or pseudobulbar palsy? Both are same or different?
So
Srishti.
pseudobulbar palsy.
Okay, Abhiram has now started to respond. He felt, okay, I am not speaking. Please come on, Abhiram.
Sir, mostly this is a case of cortical involvement. There will be affection of corticobulbar tracts.
My question is very
Then-
simple. It's a bulbar palsy, pseudobulbar.
Pseudobulbar palsy.
Okay, what is then pseudobulbar? And what
Sir,
is
in
bulbar?
association-
Explain me.
Sir, pseudobulbar palsy is a evenment type of evenment condition
good.
that affects the corticobulbar
Very
fibers.
good, very good.
Sir, in bulbar palsy, the tract is mainly the neuronal disorder that
Abhiram,
affects from
directly if
the.
I ask a question, you can give one example to me, which is the bulbar palsy. Very common condition, which everybody, all of you have seen.
Sir, in Guillain-Barré syndrome, if there is associated.
Yeah, Aishwarya, why you are not speaking then, putting on the chair? Very good. I will appreciate all of you are knowing. Very good students. But now at the end of session, you have started to respond me. I wanted from the beginning. Very good. You know, bulbar palsy, very best example is the GBS. If at all it develops, that is the GBS. Even in polio, we used to see. Will be the bulbar palsy. And it is the lower one. Bulbar, that means which part is affected? Abhiram? Which part of the
Sir, from the-
CNS?
Sir, from the
Yeah,
anterior-
Pranay is putting very good. You know, bulb means medulla. If you remember the anatomy, we say bulb from its appearance, medulla oblongata. And this is the part where centers of respiration and 9/10 cranial nerves are located. And here the bulbar and pseudobulbar, which cranial nerves are affected? 9, 10th, 11, 12th. And therefore gag reflex and all the things you can check. So in bulbar palsy, GBS, poliomyelitis example. Pseudobulbar is the upper motor neuron type of lesion. And here gag reflex will be present or exaggerated. And all the things will be present. And here we are expecting pseudobulbar because this is upper motor neuron type of lesion. Very good. But you know, in the exam, teachers are going to ask you this type of the points which you can save the time. Akshat, now we have the less time, but you can complete the CNS examination. Many points we have discussed. I'm sure it is going to be quite useful to all of you in the exam. Please now complete the CNS examination. Very precisely, smartly.
In the higher mental function, child is lying down. Child is in lying down position, comfortable. Does not follow commands. Cranial nerve examination.
Akshat, sorry to interrupt you. Such children are not going to be the comfortable at all. Naturally, with these many problems,
Yes.
I am not expecting the child is going to be comfortable, right? So that's why I'm telling you, when you make the comment, find out the proper word, that which one should I consider? Most of the time, these children are crying. Sister, why these children are crying most of the times? What is the reason? Many times these children are constantly crying or irritable. Why they are irritable or crying? Due to what problem? Any idea?
So due to pain,
Yes, somebody mentioned, we know they have the pain. Pain is due to what?
so spastic pain.
Absolutely. These children are not going to be comfortable. They are crying, irritable, and due to the pain. And pain is due to these regions, right? I'm sure that it makes a difference in our understanding. Please go ahead. I think to save the time, Akshat, just I may interrupt you. In cranial nerves, any cranial nerve is affected or an examination that you can highlight.
No, sir.
Okay. No cranial nerve is affected.
No, sir. No cranial nerve is affected. And
What was the gag reflex?
Cannot be.
What was the gag reflex?
Gag reflex was present, sir, at in the
Then
examination.
why the drooling was there?
It may be, so there's no such features of cerebral palsy. There
I
may
think,
be
I
due
think
to axial
there may,
hypotonia.
okay, there may be some aspiration also.
Yes, sir. There's a history
Due
of
to
recurrent
what? Due
LRT,
to what? Due to what?
pointing towards aspiration.
Yeah,
So then these,
in this patient, I don't expect the 9th, 10th, 11th, 12th not affected at all. May not be severely, but to some extent common. Anyway, you will and everything you have put it, please. And suppose if you are sure they are not involved, okay, then you can make the comment. No problem. But before making the comment, please ascertain yourself. You should be very confident that if the examiner is asking, I'll be able to show. Then you can make it.
yes.
Okay, go for the further motor part.
And motor system posture, supine to the right and left upper limb are in flexion at elbow and wrist joint. Bilateral lower limb, hip joint, flexion and adducted. And knee joint is in flex position. Bilateral foot, there's plantar flexion, foot are in equinus position. And bilateral great toe, plantar flexion, and contracture of bilateral elbow and wrist are noted. And contracture of bilateral knee and ankle were noted. Nutrition symmetrical on both the sides. Bilateral wasting is present. Upper arm, right and left upper arm is of 17 centimeters, and forearm is 14 centimeters. Thigh is 22.5 centimeters, and leg is 19 centimeters. Tone of exhale muscle, pull to shift maneuver, marked head, leg, and poor neck and truncal control was noted. Tone, feel of muscle, stiffness with decreased range of movement. Upper limb, there's hypertonicity is there with spasticity in both right upper and lower limbs. Formal MRC grading is difficult due to poor cooperation. However, the child has spontaneous anti-gravity movements in all four limbs with poor active motor control.
I
At
think
shoulder,
here in this type of patient, Akshar, safely you can say power is grade more than grade 3. And was it possible to uplift against gravity?
yes, sir. He is in lying down position. He
Then
is
you know,
able to.
then it is difficult for the clinician to decide 4 or 5, but you can say power more than grade 3.
Yes.
Then I think it will be safe, right? Okay.
Yes. At shoulder, flexion 3 by 5, and in right and in left it is also 3 by 5.
Okay.
In extension, right and left is 3 by 5, and in adduction and abduction, that to a power of 2 by 5 in both right and left shoulders. At elbow, flexion is 3 by 5, and extension is also 3 by 5 in both right and left. At wrist, flexion and extension are 3 by 5 in both right and left wrist, and supination and pronation cannot be checked in this patient. At hip, the power of flexion and extension is 3 by 5 in both right and left, and adduction and abduction is 2 by 5 in both right and left. At ankle, it cannot be assessed due to contraction. Power and precision, flexion and extensors are 3 by 5, and adductors and abductors are 2 by 5. Reflexes by biceps, triceps, supinator, knee, and ankle cannot be elicited due to contractures. Primitive reflexes were absent, and jaw jerk is also absent. Sensory system, touch pain and temperature sensations can be elicited. Joint pain and joint sensation cannot be tested. Cerebellar signs are absent. Laryngeal signs are absent. Spine is apparently normal in this patient, and there are no involuntary movements present.
Fine. I think other systems, any problem? Did you locate?
No, sir. Other system, there.
Okay. Come to the conclusion. Fine.
Yeah, diagnosis Arman Nishalkar, 12-year-old male child born of a non-consanguineous marriage, first by birth order with complaints of not achieved age-appropriate milestones, case of non-progressive encephalopathy, cerebral palsy, quadriplegia with global developmental delay, and grade 5 GMFCS, grade 5 manolability classification score, and grade 5 CFCS, grade 4 for eating and drinking ability score, and grade 5 for communication score with seizure disorder with severe protein. Actually, diagnosis part is this with severe busting.
Right.
Yes, global developmental delay with spastic quadriplegic cerebral palsy with axial hypotonia causing feeding difficulty with seizure disorder with contractions with bed sores with grade 5 GMFCS, grade 5 MSCS, and grade 5 CSCS, grade 4 EDACS, and grade 5 VCCS, with microcephaly and generalized wasting, possibly due to multifactorial origin, birth asphyxia, prematurity, hyperbilirubinemia, and causing diffuse brain injury.
Right. Okay, anything else you have to present?
No, sir.
Okay. Can you stop sharing for a while? Now I think we have reached to the end of time, but we can take few important points for a few minutes. I think now with this clinical discussion which we have discussed, one point, please remember in the exam, they are going to ask you for the demonstration. So you should be mentally prepared for demonstration of even the tone, muscle tone, power, internal reflexes, everything. So that I will say online discussion, we may not be able to perform that exercise, but please remember. Second thing, after this, even somebody is going to ask you, Akshat, should we go for the radio imaging in this patient? Suppose at the time of birth you were there. This following this birth asphyxia, neonatology, the baby was under your care. Should you go for this?
Sir, in an ICU itself, USG skull should be done to rule out hydrocephalus and
No, I think at the time at the time of birth action, because already it was obvious reason that the baby had birth asphyxia, therefore didn't cry, therefore all these problems are there. There is no need to go for further investigation. There is no need to go for confirmation. It does not require. Somebody has put MRI will be just add on to diagnosis. EEG can help. Why I will say add on? That's my direct question. Radio imaging should be done in such patients at the time of birth, yes or no?
No, sir, at the time of birth, it should not be done. It will not make much sense at the time of birth itself.
Aishwarya said MRI can be done to find etiology. Aishwarya, what etiology you will get in MRI? Please make your, I will say, video on and try to answer rather than putting on the chat box. No problem. Srishti, what is your opinion? Should we go for radio imaging in such babies or not?
So, since it is
and whatever answer you should explain.
So since it is a static non-progressive insult and we have diagnosed as cerebral palsy, so there is no need to do radio.
Yeah, Srishti is very clear. Why unnecessary we should go? I will appreciate you. Let me now divide and roll. Srishti is one part, Akshat is another, Aishwarya says should be done, may be done. She is smart enough to answer, may be done. So you consider. Vivek, what you will do? Vivek, what you will do? MRI. Suppose Srishti said there is no need. What you will do? Both of you are from the same institution? Different. So you can fight. There is no problem. Same institution may be the problem.
Sir, before discharging, we will do USG skull of this patient, sir, and we will definitely advise them for future, like during
what you want to see by USG. What you want to see?
Sir, as this is a patient of premature, also he was premature, so it can have periventricular leukomalacia, so which can be done in the USG skull can be done for this patient, and we will find out any brain injury and all, so we can advise them MRI in the 1 month or 1.5 months. We can
Akshat,
tell
what
them
you will do?
At the time of birth itself, there is no need to do neuroimaging, according to me, sir.
I think Akshat and Srishti both are from the same institution. Am I right?
No, sir.
No, sir.
Okay. So no problem. I thought that because you are helping each other, Better not to fight. Anyway,
Uh,
let me answer. Let me
but
answer.
after 6 months, we can
Because this
advise.
is
We should
good.
advise
This is
MR.
going to be the very common question. That's why. Long back, all of us were believed. Probably I have also discussed. Ambedkar sir was also having the same impression that already birth asphyxia or something, diagnosis is obvious. Whatever the damage has taken place, hardly it makes difference in your understanding or the management. But now it's not so. MRI should be done. The reason is, there can be some other reasons for this problem. Apparently looking like cerebral palsy, suppose even for the birth asphyxia, cerebral palsy develops later on. But for the birth asphyxia, that birth asphyxia itself may be to some congenital malformation, which we don't know. Maybe some congenital malformation. Sometimes maybe some metabolic disorder, which has presented even the vascular middle cerebral artery involvement and hemiplegia can develop. Hemiplegia is also type of cerebral palsy. And hemiplegia is not due to this even birth asphyxia or something, due to some other etiology. So what I mean to say, that cerebral palsy or its like presentation manifestations can be due to some other reasons also. Starting from malformation to degenerative disorder to metabolic disorder or some other, or even some syndromic conditions. If you diagnose, it makes difference. And second thing, even after that, if you confirm, some of these are the genetic disorder. So future counseling also, it helps a lot. And for that reason, we go for this MRI. In the past, we used to say that it does not make any difference in the management. But now, yes, it makes difference in the management. And nowadays, you must be knowing, please remember, most common cause for cerebral palsy, sister, according to you, most common cause for cerebral palsy,
The genetic is the most common.
which one? Not the birth asphyxia?
No, sir.
Okay. Vivek? What is the most common cause of cerebral palsy?
The birth asphyxia, sir.
Yeah, birth asphyxia. Because already in our patient it is there. Divyanshu also says hypoxic ischemic encephalopathy. Akshat, according to you?
Yes, sir. Birth asphyxia.
Yeah. I think it indicates that you are not read 21st edition of Nelson.
Antenatal factors are more important.
I can make out whether have you read or not. I'm sure. The reason is, if you read it, even our Peace Gupta, I'm sure you must be knowing postgraduate book. Please, that was and again, before the availability of this investigative facility, we were also taught like this, and it was there. But nowadays, people say, yes, it is there. Hypoxic ischemic encephalopathy, compared to developed countries, may be common for us, but it is not the most common. If I quote one study from our own institution, our country's institution, PGI Chandigarh, they say majority to be term delivery and 60% they cause the congenital malformation. 60%, 59.8, that means 60%. And they cause acquired 17.8%. Here data is there, and later on they got this CNS infection, meningitis, and hypoglycemia. So many other reasons. Yes, in our country, developing countries particularly, still hypoxic ischemic encephalopathy is one of the common causes, but it is not the most common. That's very important. That always we should keep in mind, and it makes difference. Somebody is going to ask you, Vivek, what is the definition of cerebral palsy? How do you define it?
Sir, it is a non-progressive, sir. Non-progressive in development of posture, sir, and other different domains, and mostly due to hypoxia and different etiologies, sir.
Okay,
Non-progressive posture developmental delay.
good attempt. I will appreciate. Dr. Pranay, can you speak out rather than writing on the chat box? Please come on. I hope that you are there on the screen. Before we end, I would like to, yes, he is there. Pranay, please make your video on. Very good. Please. At least I could see the good face. Now you can define. What is your definition of cerebral palsy?
Sir, CP is a non-progressive motor disorder of tone and posture, which occurs due to damage to the developing brain. It is a non-progressive static encephalopathy.
Right. Good attempt. One more. Abhiram, would you like to put your way?
Sir, it's actually a permanent group of disorders that affects the movement, posture, and tone of muscles. Mainly causes a limitation of the routine of the child. That is due to the insult to the developing brain, developing brain, sir.
Very good.
Up to considered up to 5 years.
My idea was to sensitize all of you. And really, I'm happy at the end. 4, 5, 6, 7 students started to speak, but that was at the end. I wanted from the beginning. So please remember for the cerebral palsy definition, somebody is going to ask you. Remember 3 words which should come. It's a chronic disorder and common in the pediatric practice, neurological, and which involve tone, posture, and movement. It's a tone, posture, and movement. It's a chronic, common neurological condition in the pediatric practice, which involve a tone, posture, and movement, which causing the limitation of the activity. Very common, which may not be like this severe, but at least causing some limitation of the activity. Further, it's permanent, but what we say, it's a non-progressive, because non-progressive lesion, it's a one-time injury. Therefore, we say non-progressive. And usually develops in the developing brain. Developing brain is defined from fetus up to the age of 5 years. Some books have mentioned 3 years. But probably our developing country, they say up to the age of 5 years. Therefore, meningitis even infant may be the part of the cerebral palsy. And commonly it is associated with comorbidity like sensation, perception, cognition, behavior, epilepsy, and musculoskeletal disorders. That is as a whole cerebral palsy. That means cerebral palsy is defined as chronic condition with involvement of tone, posture, and movement. These 3 words should come, which causes a limitation of the activity, commonly due to the one-time or non-progressive lesion in the developing brain, that is fetal up to the age of 3 to 5 years, which commonly present with the problems of sensation, perception, cognition, behavior, epilepsy, feeding issues, and musculoskeletal problems. That is complete definition. I think part of management will leave over here due to the lack of time. Plus, please remember, and all of you know that probably most of the universities, CNS is going to be the long case, and cerebral palsy is the most common condition. So I think you should be well prepared. And let me end over here with the word of appreciation. First, the Akshat. You have really come with a good presentation, good preparation. And I would like to appreciate even your mentor, Dr. Kiran, and even your institution. I understand that they also take more pain efforts to make the students for motivation and preparing presentation. And certainly, I will say I started for the motivation, sensitization to participate in the discussion. Initially, that was hesitancy, but ultimately so many students started. Srishti, Vivek, Abhiram, Aishwarya, even so many students, and that's good. Please, I request all of you for learning, always participate in the discussion. Maybe even wrong answers. I am also not sure what I discuss. Every point may not be right. It happens in our medicine. It does not mean that we are wrong, but that's a process of learning. And certainly, I will say, Latur, I know, small place in Maharashtra, but medical college. And Madam has, I will say, made the good efforts to prepare the students. And there was a good presentation, good discussion. Let me end over here with this, I will say, the word for all the whole team who is preparing, I will say, starting from our Yogeshwar to Dr. Nehal, Dr. Purvi Patel, Dr. Arif from Vijay Medical College. So many faculties are taking, I will say, efforts, motivating the institution, preparing them, approaching them. And that's why we are able to learn for 2 hours for this discussion. Of course, we should not forget to appreciate our office bearers, our President, Dr. Neelam Mohan, Dr. Ruchira Gupta, and President-elect Sir, Singarvelu Sir, for providing this platform so that all of us can learn. Thank you very much, all of you. I end over here and over to you, I think, Dr. Arif or Dr. Purvi. Thank you very much.
Yes, sir. Thank you so much, sir, for
Thank you,
such
sir,
an
for guiding us.
enlightening and practical discussion. Really, I hope all students have learned a lot from this today's case discussion. We sincerely acknowledge and thank mentor and presenter also for their hard work. Excellent presentation for today's case presentation. And lastly, I want to thank all faculty members, resident and participants for their active participation and support in making this program successful. So thank you, everyone.
Yeah.
We are ending here.
I think
Thank you, sir.
all the students are so ready. I request Dr. Srishti, Vivek, Akshat, Abhiram, Aishwarya, whoever is presenter, we should be there for discussion, whatever the case it is. So please, every Tuesday, every Thursday, and I'm sure if you come with this type of the discussion, probably hardly there is any issue in the practical exam because you'll be well prepared. So with this remark, we end over here. Thank you, all of you.
Thank you, sir.
And
Thank
good
you,
night.
everyone.
Good night.
Thank you so much.
Yeah.